Hello, everyone. Welcome to today's speaker series. Thank you for joining us. My name is Rosa Staltieri, and I'm the Knowledge Translation Manager with CanCOVID and the speaker series moderator. Burnout was already far too common in the healthcare workforce before the pandemic, but COVID-19 has made the situation much worse. Healthcare workers in Canada are experiencing endemic levels of burnout directly related to understaffing and work overload. It is a great pleasure to welcome Dr. Bourgeault, who will be discussing poor health workforce planning and why data to support planning is critical. Dr. Bourgeault is the chair in gender diversity and the professions at the University of Ottawa, and also the lead of the Canadian Health Workforce Network. So before we get started with the presentation, a few items to note. As we ask you that you ensure that your microphones are on mute during the presentation. And for the 10-minute question and answer period, we welcome you to ask your question by raising your hand or by typing your question in the chat box at any point during the presentation or after the presentation. And so without further ado, I will hand over the floor to Dr. Bourgeault.
Thank you so much. I'd really like to thank the organizers for the opportunity to present. I'm located here in Ottawa, the unceded territory of the Anishinaabe people, the traditional guardians of this land. So thank them for that opportunity to greet you here. So as Rosa outlined in the introduction, I would like to speak to the pressing issue, which is the state of health workforce and health workforce decision-making in Canada, and make a case for how the time to advance better health workforce planning in Canada is now. So if we conceive of health systems as a coin, it is important to recognize that there are two sides of that coin. On the one side, you have population needs or demand. This includes that which results from increasing aging, chronic, but also infectious diseases, and increased mental health needs. On the other side, you need to ensure that you have the health workforce to meet the needs of the population. That is the capacity to meet the needs. Unfortunately, in Canada, we don't know as much about this side of the health system coin. So in the words of many, including the WHO, health workers are the foundation of health systems. They are foundational in terms of the cost of the health system, being that they are roughly 70% of the costs. And in Canada, that translates into $175 billion, which is 8% of GDP. Now, keep in mind that this does not include the personal and public investments into training of the health workforce. So key elements of the health workforce that we need to know about includes the supply or numbers, the mix, who is all providing what type of care to whom, and distribution or where, and also in support of the health workforce. And this reflects all four elements of the quadruple aim. So if we look specifically at the issue of support, it is very clear that we are not supporting our health workers through this crisis. And here are a few of the headlines emerging. The COVID crisis, too few are talking about healthcare workers' mental health. Health workers facing immense psychological toll from the pandemic. I've never seen so many nurses crying during a shift. And nurses say stressed out healthcare workers are nearing the breaking point. These are the words and more that we are hearing from those participating in our healthy professional worker interviews and survey, and we are still out in the field with this. These are some links provided here. So the burning platforms are this. Health workers account for more than 10% of all employed Canadians and over 2/3 of all healthcare spending, which accounts for almost 8% GDP. Health workers are experiencing endemic levels of burnout and work overload, which are a direct result of poor planning, which in turn are a result of poor health workforce data. And the pandemic has exacerbated these trends, causing critical and systemic risk in the short term, but with longer term implications for attrition. There is a clear need to focus upstream. the levels of burnout that we are seeing can be directly linked to work overload and can in turn be directly linked to poor planning, which can in turn be linked to a lack of health workforce data. And if we don't intervene, I'm afraid what we are going to see downstream is significantly rising attrition from the health professions. This is echoed again and again in our interviews. I'm going to stay until the crisis is over and then I'm out of here. Or comments like, I'm replaceable. So a key solution to this existing and pre-existing and growing crisis is an upstream solution, an enhanced health workforce data infrastructure. So it's critical to making decisions about this essential human resource, our health workers. So let me walk you through where we are presently at with respect to health workforce data in Canada, because many of you are probably saying, we have tons of data on health workforce. What are you talking about? So pictured here are a number of silos, and I chose that symbol quite purposefully because we have data. These data exist in silos. The data are not, by and large, not standardized. So we have a tall silo for physicians, which is to indicate that we have good data about physicians, about their identity, their location, how they practice, and a link to patient outcomes. The silos get smaller and smaller as we move across to nursing, where we don't have as high quality of data, less so for pharmacy, physiotherapy, and occupational therapy. The data that we have on regulated workers include less than what would be identified as the bare minimum of number, so just number, head count, not how they're practicing or any nuance in terms of how much capacity that they have, simply a head count. Their age, their gender as a binary, and province or territory. Now, those are what are all housed at CIHI, the Canadian Institute of Health Information. All of those are the holdings that they have. We don't have any data on unregulated workers. For example, personal support workers, we do not count them, not even counting them. We have registries in Nova Scotia and Alberta, but even those registries are very difficult to integrate. And we also know very little about the broader mental health and substance use workforce, a workforce that we are going to need right now, during the pandemic in terms of the growing mental health needs. So there are a lot of question marks here. There's a lot that we don't know. And what we do know does not map onto the national occupational codes. This I find fascinating. So it's very difficult for us to interlink those. So this is a remarkable and indeed a remarkably bad situation that needs to be ameliorated. So let me tell you a little bit about what we do know. We do know from data holdings that women hold a unique position in healthcare, in that they constitute over 80% of the health workforce, and this is growing. And what's really fascinating is how the health workforce is more feminized in Canada than it is internationally. The international average is 70%. So we have more women in healthcare. And indeed, this is the sector where women primarily work. So pictured here is a chart that depicts the growth across the labor force, the red line, a blue line for the increase of men in the health labor force, and a yellow line for women in the health labor force. So you can see that it's increasing, but yet we don't collect any more higher quality data about them. In addition to all of those other things that I highlighted that we don't know about the health workforce, other things that we don't know, and this is really quite remarkable given the importance of a gender-based analysis plus for the Canadian federal government, and this has been written in to the minister's mandate letters, all ministers, to take a GBA plus lens. There are no data in Canada on the racialization of health workers. There are no data on Indigenous identity of health workers. There are no data on their levels of disability. There's also variable data on language of service. And these gaps contravene a number of important pieces of federal legislation: the Employment Equity Act, the Official Languages Act, and not the least of which to say that we will not be able to say very much in terms of our progress on the calls to action to increase the complement of health workers from the Truth and Reconciliation Commission. So quite remarkable. So I'm not here to just talk about problems. I'm really solutions oriented. So what kind of health workforce data do we need? So ideally, it should be standardized and it should cut across different professional workers and be interprofessional. It has to cut across those silos. And that should be guided by a minimum data standard. What are the core data elements that we need in order to undertake effective planning and to recognize the identity of our health workforce? So that's for the quantitative data side. But it's also important to note that we need health workforce intelligence of a qualitative nature to address those issues that are unquantifiable. So this combination of quantitative and qualitative data is what would go into a toolkit for health workforce planning. Again, it's not just data. We're interested in tools to help planning and decision-making. An example of an integrated health workforce planning toolkit is exemplified here by this diagram. This was developed by colleagues at the Canadian Health Workforce Network, Dr. Sarah Simpkin and Carolyn Chamberlain-Rowe. And this was done for an integrated primary care workforce plan for the Toronto region. It depicts the two sides of the health system coin, the population health side and the workforce side, represented by profiles. This helps us to understand what services are required and available or capacity. Also depicted here are the important alignment and allocation steps, because health workers may be available numerically in terms of capacity, but less so geographically. So that's really important to have these two of their steps. Qualitative tools represented here by scenario analysis can help to gather local intelligence, which can inform different scenarios affecting the population, the workforce, and allocation elements. Things like increased population growth, issues around predictions around retirement of health workers. So the scenarios could affect different sides. And allocation is, if we have certain growth, vertical growth, how is it that the city is going to make determinations about not just where parks and schools are going to be, but healthcare services. Ultimately, what is required is a set of high quality health workforce data, ideally standardized across multiple professionals in order to take an interprofessional, sector-focused approach. That is what needed to really undertake this type of approach. Right now, we're doing this work with at least two hands tied behind our back. I know we only have two hands, but it feels like more sometimes. Having a national minimum data standard to help produce a standardized minimum data set is not the holy grail. There are many countries who have developed such a standard. I'll give you one example. If we look to Australia, a similar federated system, it moved to nationally coordinated registration in 2010. And that incorporates a standardized national health workforce data set, which covers 16 professions. We can do this without national registration. National registration just really helps. This has been a national asset for health workforce planning, which has yielded two key outputs. So the first, in steady state pre-pandemic, it fed into a health demand and supply utilization patterns and planning tool, or the heads up tool, which is a new integrated source of health workforce and services data that informs health workforce planning and analysis. Second, This data set created a ready infrastructure for a more effective pandemic response. They were quickly able to develop a pandemic subregister of recently retired health professionals that would be available for surge capacity. They developed a national immunization workforce to roll out the vaccine in an efficient and effective manner. And they were also able to assess the impact on the training pipeline, because the data set not only covers practicing professionals, but trainees into those professions. This is doable here in Canada. What we need is a coalition of health workforce supporters and a roadmap for that coalition. This would include a call for more and better data on all health workers across key sectors. Doesn't have to be all right away, but let's build on the foundations we have and move forward. A second goal is improved access to health workforce data across users. Sometimes data exists, but we can't even access it. It can take years and thousands of dollars. Third, we can then develop more and better health decision-making tools like the Heads Up tool and like the planning model we've developed in Toronto for staffing and planning, and ultimately to address the workload, which affects the mental health of our health workers and the sustainability of our health workforce. The means by which to achieve these goals, it is a broad-based coalition, and I'm hoping that some of you are really interested in becoming part of that. Who could or should be involved is really multi-sectoral. So we would have unions and professional associations representing the interests of all health workers, the regulatory authorities that represent the interests of the public through standards, the data custodians at CIHI and StatsCan to house and enable access and co-develop decision-making tools, health workforce scientists to support the development of tools and data standards, educators to make evidence-informed decisions about the pipeline and enrollments, employers to identify data needs to support staffing and decision-making, and the federal, provincial, and territorial governments to support a coordinated initiative, and the patients would be at the center of this. A potential vision, and I want to stress a potential vision going forward, could include the following, in keeping with our analogy that population health and health workforce are two sides of the same health systems coin. In the same way that the Public Health Agency of Canada was developed out of our last crisis, the SARS crisis, where all the different departments and divisions were brought together into a coordinated agency led by a chief public health officer. The same could be done for health workforce. We could propose a health workforce agency, Health Workforce Canada, for example, that gathers together all of the different departments and divisions within Health Canada and the Pan-Canadian health organizations, of which there's an existing table that we could build off of. And this could be led by a chief health workforce officer. This could be like the Public Health Agency as being part of Health Canada, or arm's length, similar to the Pan-Canadian health organizations, or ultimately a coalition led by one, such as CIHI, or another in a coalition, some type of coordinated mechanism. We can't keep doing this off the sides of our desks. This has to be something squarely on a group of people's desks. Similar organizations exist internationally with enormous impact. And I could give you an example of Health Workforce New Zealand, an amazing work that they're doing. Having one coordinated office to really move forward our health workforce data infrastructure, develop high impact decision-making tools that could be shared with the provinces, territories, and regional health authorities could help to enable them to make better local decisions in a similar way as to that which we've done in Toronto. So critical next steps would be to gather together this coalition of health workforce supporters across different stakeholder groups, to co-develop an action and communications plan and refine this plan based on feedback from a broad coalition. This is just one vision. I would like to hear from others. The best time may have been 10 years ago when this was recommended by an all-party parliamentary committee on health in 2010, the same year that the developments were made in Australia. But the next best time is now. The pandemic may be just the impetus to enable us to make significant advances in health workforce data infrastructure in support of better decision-making. And in that sense, to support the health workforce, we need to do much more than just clapping. We need to start planning and really supporting them. And I'd like that to be a key legacy of the pandemic in support of our health workers. So we at the Canadian Health Workforce Network and so many others, partners at HEAL, the Canadian Health Leadership Network, the Canadian College of Health Leaders, the Canadian Federation of Nursing Unions, and elsewhere are ready to help. And I'd really like you to join us. So thank you so much for the opportunity.
Thank you so much, Dr. Bourgeault. So right now we are in our 10-minute question and answer period. And so we do have one question right now, and the first one is from Donald. And the question is, what organization and who will take the lead? Is there a role for high in this space? And I think he's referring to the health system capacity in which you help force officer you were just describing.
Yeah, absolutely. I'm rather agnostic about who should take the lead. I just think someone should take the lead. So I'm really open to suggestions from anyone. I think that, there exists right now a pan-Canadian health organization table where they're talking about health workforce issues, but it does need to be squarely somebody's job. I think the team at the Canadian Institute of Health Information are doing a monumental task with not enough resources. Even if we use the analogy that 70% of the cost of the healthcare system are health workers, let's just say, and I don't know the exact budget, but I know it's definitely not 70% of the CIHI budget dedicated to the health workforce. It's less than 5%. So, remarkably more resources. But I don't want to just focus on CIHI because there are a lot of other pan-Canadian health organizations, other organizations, departments and divisions within the Public Health Agency of Canada and Health Canada that can be brought together and more coordination and really more support. And we in the academic community of the Canadian Health Workforce Network want to support that. And I know that many other stakeholder organizations, as we mentioned here, are also really keen to move things forward. They want to make better decisions and they need the information and tools to make those better decisions.
Thank you so much. And so the next question is from Evangeline. And the question is, I wonder about new immigrants who experience a lot of obstacles in becoming regulated professionals and who can represent their needs in this type of work.
That's a really, really important question. And across many different countries, we looked at this internationally. One of the registers that was created was on internationally educated health professionals and to be able to utilize the skills and resources that they have within the system. And so I think that that's a really important resource to bring. We know very, very little other than those ones who are registered, but the internationally educated health professionals who have training as nurses or midwives or dentists or pharmacists elsewhere, we don't have a good data set to capture that. So that's a lot of missed opportunities and missed information. So I think that would be an important resource for us to tap into.
And so we do have a comment from Linda here saying this is a national potential crisis. The lead must come from the federal government, even if it is about bringing us together like it did in the late 1990s. So not a question, but just a remark. The next one is from Riza. Does that mean that someone licensed in one province will automatically be licensed in all of them? The same rules for allowing foreign trade professionals, or just that we'll try to have better data?
Yeah, so this is a really important question, and it allows me to delineate what we mean by registration and regulation. And so having a national minimum data set for health workforce, we can proceed with that without even going down the path of national registration or national regulation. And it's important to note that in Australia, they moved towards a system of national registration, but the regulation still happens, but it's coordinated across the states and territories. So I'm trying to kind of break this down into what do we need to move forward. National registration would be great because we could simply apply a minimum data standard to national registration and we would have national data sets. That would be amazing, but we can proceed without that. With an eye that would make a lot of sense. And so there are conversations already happening in terms of sharing data across jurisdictions, particularly in the context of virtual care, where health professionals may be working across boundaries, and how does licensure actually capture that? So I think that there's a multi-layered conversation, but I don't want us to get too mired in all of the weeds where we can just get back to, you know, some of the basics and start first with the foundation of a minimum data standard to create an interprofessional minimum data set. Then we can build really good sector-focused interprofessional tools on that to do much better planning. And then that would hopefully help with, you know, workload and staffing and pipeline issues. Yeah.
Our next question is from Vivek. Have you looked at issues for public health workforce data?
Yeah, so here's another health workforce and a sector that we don't have really good information about. So the work that we did in Toronto was with the primary care workforce, and that was hard to kind of put, you know, sort of brackets around who is in, who's not. And that's how we, you know, worked with our local decision makers to kind of say, well, how would you like to frame who's in that health workforce? The same thing could be done with the public health workforce. And to give us some much better information, for example, on how many masters in public health do we need? How many chief medical officers do we need? What are the different types of skill sets that we need? Public health nursing, community health workers, etc. That's an undiscovered country in the same way that it's an undiscovered country in long-term care. You know, when we don't count workers, we have no ability to really do any evidence-informed planning. Older adult care, mental health care, the public health workforce sector. It's fascinating because when the Public Health Agency first started, they had a health workforce, a public health workforce strategy. But, you know, if you don't have the data to create a strategy, like, I just don't know where you go from there. But very, very important sector and good question. Thank you.
The next question is from A. How do we ensure that we have racialized Indigenous folks at the decision-making table to ensure that action plans acknowledge the lived experiences of POC healthcare workers and the very unique experiences we have in the healthcare system?
Absolutely, really, really important question. So thank you so much for that. It's really important for not just, you know, a pointy-headed white settler academic to kind of say, we need to collect these data and to not consult with groups. So we have brought to the table different Indigenous-led health professional organizations, the Indigenous Physicians Association of Canada, the Canadian Indigenous Nurses Association, and the National Aboriginal Council on Midwives, and they're all really keen. And they understand the nuances of, you know, how do we ask these questions? How do we determine identity? These are complicated issues that I would want to make sure are Indigenous led. And the same thing that we would do for Black and people of color, health professionals of color. So we've been working closely in partnership with the Black Physicians of Canada and a Congress of Black Nurses and others. So I think it's really important to work with leaders in those communities to lead those initiatives. I'm pointing out that this is a gap, and it's a remarkable gap. How do we fill that gap? We really do need to follow folks in these communities in moving forward. And the same way that we've done that with partnerships with Société Santé en Français, you know, to address issues about the ability to access services in French outside of Quebec. And so we want to kind of reflect all of those different elements of equity to be led and to have them part of the coalition and leading on those particular initiatives.
Thanks so much. And we have another question from Kendra.
Could you talk more about how this coalition could reduce burnout or compassion fatigue on the healthcare front lines? What sorts of preventative measures or relief could they potentially offer that is different than what is being done today?
That's a really, really important question. And thank you, Kendra, for asking that, because it probably, to a frontline health professional who's incredibly stressed out right now, really on the brink, and you're telling me you're going to collect better data on me, I can imagine that that's a hard sell. And so that's why I'm trying to create this pathway that, you know, there was this analogy that people use in public health, is that, you know, the doctor is at the end of the stream and he's pulling out all of these people out of the stream and applying artificial respiration. And as soon as he gets somebody revived, he goes back and pulls somebody else out. And then at some point he sits there and says, I'd like to know who's pushing them in upstream. So that's why that R is an analogy to kind of move upstream. So we absolutely have to do something to support the health workforce right now. The healthy professional workers study that we're doing is we're trying to kind of identify downstream activities to support them here and now. What are promising practices? But every time we ask somebody what are the issues, is it because of your personal life or your family life or work, everyone says without a nanosecond, it's workload. And so we have to move that back upstream. The part about planning, if I look at it, you know, for the older adult care, the acuity levels in long-term care have gone up like exponentially in the last 5 years. So long-term care looks like acute care, retirement homes look like long-term care, and home care looks like what was happening in retirement homes. Now, if we could capture the population health level and match that with what are the needs, then we can create standards around staffing mix and ratios. We can, and that would really help to address workload, but ultimately it would feed back into training institutions about how many workers do we actually need. You know, there's a very interesting dialogue right now in terms of how many personal support workers we need in Ontario. A recent announcement, and the Personal Support Workers Association says we need 21,000. I mean, I don't doubt that number, but wouldn't it be better if we actually counted and actually did, you know, some evidence-based planning around this to really support folks? That's what I'm asking for.
Thank you so much, Dr. Bourgeault. And we are a couple minutes over, so we're going to close the session for today. So on behalf of the CanCOVID team and network, we thank you so much for presenting, taking your time to present to us on this really important and informative topic and research. And just a few announcements. Please join us next week for our speaker series on March 2nd with Dr. Mel Cragdon, who is the medical director of the BC Public Health Laboratory. And also join us for a special event on Monday, March 1st from 1 to 2:30 Eastern Time for a special interactive session with Canadian scientists investigating the impact of the COVID-19 pandemic on various aspects of mental health for patients, healthcare providers, and the public. This event will be hosted by Dr. Katrina Mullaney, who is the CanCOVID theme lead for psychosocial and behavioral sciences. So hope to see you all there next week, and have a great rest of your day. Bye for now.
Thank you.